Thanks so much for coming. So I wanted to just start off and say I'm really honored to be here and to be able to give this talk. I have not given this talk before, so please bear with me. Some of the slides I've done before, but this is the first time getting together a talk on LGBT elders, so if I have to look at my notes or something, please bear with me. But I was first motivated to start to do, come on in. To do this kind of talk and to do this kind of work really when I was in grad school, and for my health, aging, and disability class I had to do a paper, and I chose to do it on healthcare power of attorney for LGBT elders, and that's when I first started doing some research and learning about it. And then I did my internship my last year of grad school at the VA, and I was asked to do a talk at the VA on LGBT healthcare issues within the healthcare system. And so through that research and what Tracy asked me to do, I kind of put this together and hope that you guys learn something out of it. So feel free to ask me any questions. I'll probably talk for about 40 minutes or so, and then I'll leave time for questions and comments as well. And I'm first time using a clicker, so this will also be a new thing for me. So today I thought I would just really briefly go over some terminology so that we're all on the same page. I wanted to paint a picture of what an LGBT older adult looks like, so to give some information on that. I wanted to talk about 3 key challenges that I think LGBT elders experience as they age. And then I wanted to talk about 1 or 2 policy gains that we've seen in the healthcare system specifically, since that's where my passion lies and what I know most about. And then I put together a couple of slides on what I think our role as social workers is in working with LGBT elders or the LGBT population overall. So, we also often hear GLBT, LGBT. It doesn't really matter whether the L is first or the G comes first, but just so that we're all on the same page, gay is a man who self-identifies as having an emotional, sexual, or relational attraction to other men. This is also an overarching term that's used for this population. Lesbian, a woman who self-identifies as having an emotional, sexual, and/or a relational attraction to other women. Bisexual is a person who self-identifies as having an emotional, sexual, and/or relational attraction to both men and women. And then I also wanted to include transgender, and that's an umbrella term for people whose gender identity or gender expression differs from what they were assigned at birth. I wanted to mention that they may or may not choose to use hormones, so this does not disregard their choice of using the term transgender. Some choose to alter their body with hormones and some do not, just like some choose to alter their body with surgery and some do not. And you may often see the terms M to F or F to M, and those just mean male to female or female to male. And then I thought I would include for this talk that an elder or older adult can be somebody over the age of 65. And in a lot of studies, they actually include people that are 50 and over. So some, and in one statistic I have, it's 40 and over. So, but mostly, mostly I'm talking about people that are 65 and older, but I do want you to know that some of the research does use people 50 and over. Okay, so what does an LGBT older adult look like? So I put up a few things up here that in general, as we know, our population is aging. Come on in.
Thank you.
Absolutely. Our population is aging. The baby boomers just turned 65. The first, the oldest baby boomers just turned 65 a year ago. And so the 65 plus population is expected to double in the next 30 years. It's really hard to estimate how many LGBT people we have in our society, let alone how many LGBT elders we have in our society. So there are a lot of different statistics that are thrown around. But some of the research has estimated that it's between 3 and 8% of the overall population is gay, lesbian, bisexual, transgender. And that number, again, is going to double by the year 2030. So there could be as many as 3 million. There are a number of different reasons why we might not know. Some of it has to do with homophobia, social stigma, discrimination. There are many reasons why we don't actually know how many there are, but we can have an estimate. And so the other thing that is really important to recognize about LGBT older adults is when they where they came from in history and what they experienced during their, early adulthood into mid-adulthood and now into their elder years. And so they grew up during a time when they experienced discrimination and victimization. This was a time that being a homosexual was considered a psychiatric disorder, and it was even in the DSM-3 and wasn't removed until the early 70s. And I have another slide that's a timeline, and we can see how old somebody was in their lifespan when that happens. So this population also really relies on families of choice, and those are people that they have chosen to be as part of their close circle or their family circle. They may not be biological, and there are a couple of different reasons why they rely on families of choice. Some of it is that they may have been estranged from their biological family or they didn't have kids. So this community is really tight with people that are really close with them, and they consider their friends to be their family. And another thing that this population experiences is a lot of unequal treatment under the law. So many of the policies that we have, both state policies and federal policies, do not treat people in the LGBT population as equally as they treat heterosexuals. So most of our policies are designed around the presumption of marriage, or they prioritize legal and biological families. So this slide, hard to see, and I'm laughing because I had a feeling this was going to happen, and especially with this setup, it's a little bit more challenging. But really, this is just a timeline of what somebody in their early 70s would have experienced throughout their lifespan, and all of the history that has happened throughout their lifespan that has to do with laws around discrimination and victimization to people in the LGBT community. So again, just to mention, they did grow up during a time when homosexuality was in the DSM-3, and it was taken out of the DSM-3 in 1973 when this woman would have been 33 years old. So she spent the first 33 years of her life and people around her thinking that she was, a mental case, or had a mental health disorder, or was anti-family, all these ideas for the first 33 years of her life. And then the other thing I wanted to point out, that it wasn't until she was 42, in her early 40s, in 1982, that Wisconsin was the first state to outlaw discrimination based on sexual orientation. So nice to know that we live in a state where that was. But again, that wasn't until she was 42. So that means, maybe getting a job or getting housing, she would have been discriminated against based on her sexual orientation. Yeah?
But was she out or not? Because some people might have not.
Well, that's true. So that brings up a whole nother layer. So maybe she wasn't out, and then there was a lot of fears around coming out, or if she was out, she could have been discriminated against, or maybe she wasn't out, but she looked like she was a lesbian, and then she could have been discriminated against due to the way she looked. So that you're right, there are multiple layers going on there. And then it wasn't until she was in her early 60s that the Supreme Court struck down sodomy law. So she was in her early 60s when that happens. And then obviously much later in her life, in her mid-60s, she saw that gay marriage was legalized in Massachusetts, which was the first state in 2004. The other thing I wanted to mention on this is that when she was in her mid-40s is when the AIDS crisis happened, and that was a huge milestone in possibly in this person's life. So there was a lot of discrimination potentially against all of her friends, her family, and just to see a lot of her friends and family be hurt by this AIDS crisis. And again, she was in her mid-40s, so she was potentially fully into her career, maybe having children, whatever. Okay, so to continue on with painting a picture of what an LGBT adult would look like, discrimination and social stigma affects the quality of life for LGBT elders. So I put this statistic up because I thought this was really interesting, that LGBT elders are only 20% as likely as their heterosexual counterparts to access any needed services such as food stamps, senior centers, housing assistance, meal programs, and other entitlement programs. So social stigma really gets in the way of full participation in the community for this population and accessing needed services. And again, this can stem from fear of discrimination or actual discrimination. And then this last statistic was really eye-opening for me. A third of lesbian and gay baby boomers identify discrimination about their sexual orientation as their greatest concern about aging. So if we think about the aging population overall and think about all the concerns that they have, whether that's changes in their body, whether that's where they're going to live when they get older, who's going to take care of them, are they going to have enough money to survive? A third of the people in this LGBT population, their greatest concern is discrimination for who they are. So add that on top of all the other fears and concerns that as people age they have. And that was really sort of eye-opening for me to think that they really have a lot that they're thinking about. So like I said at the beginning, I want to talk about 3 important challenges that I see LGBT elders experiencing as they age. Move my notes here too. Okay, so the 3 challenges that I want to talk about is reduced financial security. I'm going to talk about healthcare issues, health disparities and inequities that this population faces, and I'm going to talk a little bit about their reduction in social support and community engagement. Okay, so there is this myth that lesbians and gays tend to be well off and of a higher socioeconomic status. Well, we can see by looking at this that that actually is not true. So we see that, and again, this is people 65 or over, okay, that senior straight couples are about a little over 4.5% of senior straight couples live in poverty, and then it goes up from there. So we see that lesbians are at the greatest risk of being in poverty. And as we move on to the next slide, we'll see that that really has to do with the gender gap in wages. We still have that present day, 2012, there's still a gender gap in wages. So think back to a time when these people were really in the workforce. They could be discriminated against in employment. They had limited job opportunities due to their sexual orientation. So throughout their lifespan, they have had earning disparities. They've had reduced life savings. The amount of Social Security that they're collecting now is going to be reduced because they weren't paying as much into the system. And then specifically for elder lesbians, they're 2 times more likely to be living in poverty than their heterosexual couples. And again, this has to do with a wage gap when they were in the workforce.
Megan?
Yeah.
Can I ask a quick question?
You certainly can.
Did the slide before this where you showed this one,
Yeah.
did the research behind this take into account at what age they came out?
No, not to my knowledge. I'd have to go back with a fine tooth and comb, but not to my knowledge. But that is a good question.
Because I would
Yeah.
say one thing I think that would be skewing these is the number of lesbian and gay individuals who were in a heterosexual marriage for whatever reason, for however long, that would be different for LGBT younger adults.
Absolutely.
If that makes sense.
Absolutely
Okay.
it does, yeah. And as far as, that's a good question, and overall, there's not a lot of research done on this population.
Yeah.
And so it would be great if we could get research that was as specific as what you're talking about, and I'm not even sure that it's out there yet. So call for research and for this population overall. So
Thank you.
good question. So then the last point on this slide is that about 47% of lesbians report having less than $10,000 in savings as they retire. Whoa, who can live off of that? That is, it's very little. So who's going to take care of them, and they couldn't afford to move into a long-term, care facility or anything like that. Okay, so LGBT, I also wanted to point out, I put these statistics up here too, because this shows that, and we know this as social workers and as people who have been studying social work, that people of people that have lower incomes tend to be more isolated from certain services, and it's no different for the LGBT population, and especially as people age. So LGBT older adults with incomes that are less than $20,000 are 3 times more likely to experience loneliness than somebody with an income of greater than $50,000. And so what we know about people that experience loneliness, they tend to have more likelihood of memory loss or serious illness. It impacts their mental health. It impacts where they live. It impacts, like I said, mental health, so sadness or depression. So really their reduced income and the less money that they have really affects where they live, who they are, and what they do as they age, and what kind of services that they are able to access. So, I'm not going to go through all of these specifically because this is an entire class or an entire section of a policy class, but to know that lesbian, gay, bisexual, and transgendered people overall have unequal treatment under the law. And this really affects elders as they retire, as they age, and especially as they get closer to the end of life. So many of our federal policies that we as citizens of the United States are entitled to get are not passed on through partnership in same-sex couples. So they're not equally eligible for Social Security. So in a same-sex, in a heterosexual marriage, you can share Social Security benefits when somebody dies. Again, I'm not going to get into the specifics of this. Hopefully you'll learn it in your policy class. That cannot happen with same-sex couples. So there are no survival, spousal, or death benefits when it comes to Social Security. And as you can see, I put a few statistics up that lesbians receive 31.5% less in Social Security. Again, that really has to do with the wage gap too. And then Medicaid and long-term care. So when somebody needs to move into a long-term care facility, they have to do what's called Medicaid pay down or Medicaid spend down. And if you have a same-sex couple and somebody needs to move into a long-term care facility, and the other person in the couple does not need to, and they have a shared home, there's a great chance that they can lose that home, lose their shared assets, and even become homeless. Because they are considered and viewed as friends in our society. They're not viewed as a married couple. So even if they were together for 50 years and had a home together, they could still lose that. Really sad and devastating, and this causes a lot of financial hardship for people as they move into long-term care facilities and as they move towards end of life. Same thing, employee pensions, estate taxes on inheritance of a partner. So like I was saying, you're viewed as friends, so if you inherit your partner's home, you would have to pay taxes on it, even if you lived in that same home for 50 years together. And then there are no veteran benefits for partners. Okay, so moving on, any questions before I move on to looking at some of the health challenges that we see for this population? Great, okay. So this is really, I did my internship at the VA, like I mentioned, and this is really where my passion lies. I'm really interested in health disparities overall. So the next couple of slides that we're going to look at is a survey done by Lambda Legal, which is an LGBT advocacy organization. They do some really wonderful stuff. And they did a survey in 2009. They surveyed 5,000 lesbian, gay, bisexual, transgendered, and people living with HIV. And they asked about their fears and concerns around healthcare. So the next slides are not specific to elders, but all of the research that I've read, they have very similar issues, and then I'll talk more specifically about the disparities that we see, health disparities that we see with elders. So again, this was a survey, and they asked individuals, the individuals who feared being refused care based on their sexual orientation, gender identity, or living with HIV. So we can see that obviously transgendered, more than half of the people surveyed who were transgendered feared being refused care based on their gender identity. And a little over 9% of lesbian, gay, bisexual people feared. And again, discrimination in healthcare, social stigma, and really, it also can do with cultural competency within the healthcare system overall and some of our policies. And I'll try to get into that a little bit later. And so if we look at this statistic, these are individuals who feared being treated differently based on their sexual orientation, gender identity, and people living with HIV. Wow, 73% of the people that are transgendered in this survey felt that they were going to be treated differently because of their sexual identity. And almost 30% of the lesbian, gay, and bisexual people. So think about if you were aging as well and some of the fears and concerns that you would have going to a healthcare provider. And then this one is really high. And so this is a percentage of individuals concerned that healthcare providers are not adequately trained to deal with people within this population. And so almost half of the lesbian, gay, and bisexual people surveyed feared that their healthcare providers were not adequately trained, and about 90%, so almost all the transgendered people. So the thing I wanted to mention about elders is that, you know, as we age, we tend to utilize the healthcare system more. Healthcare issues become more common as we get older. And if we look at the history of LGBT elders before and what they grew up in with this, you know, history of discrimination and victimization, that they can really have fears around utilizing the healthcare system and feeling like their providers are not adequately trained in the issues that they're dealing with. And I also want to mention that, and I think the statistic will come up later, but see if I can remember it. 70% of the people living with HIV are 40 years and older. 30% of people living with HIV, I have the statistics so I can't remember, but if we look at these numbers, we can see that if you're lesbian, gay, bisexual, you're an elder, you are a higher likelihood of having HIV. So these numbers would be even higher probably for elder LGBT population. And there are reasons that the elders have a higher rate of HIV. Some of it has to do with medical technology, antiretroviral drugs, and some of it actually has to do with the fact that they are contracting HIV later in their life. So what are some of the health, I moved, sorry, jumped ahead of myself here. So I just wanted to put up, this is what they experienced. So this is from the same survey. And so a little over half of the gay, lesbian, and bisexual people surveyed, and 70% of the transgendered people reported experiencing some form of discrimination when they did access health care. And they reported being blamed for health status, refusal of care, subject to harsh or abusive language, and even being physically abused. And so if we look at these numbers, we can see that this would be even more devastating for people who are low income, people who are racial and ethnic minorities, and maybe even people that are elders. And so what ends up happening is people end up using the emergency room. They don't have regular access to care, or they don't utilize care. And the statistic up there that had to do with inadequately trained healthcare providers is, do they know the risk factors of this population? Are they getting the preventative screening and tests and services that they need and deserve? Okay, so what are some of the health disparities that we see with our LGBT population and LGBT elders overall? Is that we see overall they have worse health outcomes, surprise. They are more likely to delay needed services and care. Well, we saw from those statistics before, because they really fear going to the doctor. They fear that they're going to be discriminated against. They fear coming out to their providers. There's a lot of fear around talking about either past sexual partners or coming out to their providers about their sexual orientation or gender identity. There's a lot that we don't know about gender identity and gender expression as people age, so there's not a lot of research done on that, and hopefully there will be over time. Lower rates of health insurance. Well, this is really for people that are 65 and under. This is before people are eligible for Medicare. Some of the reasons that we see lower rates of health insurance is because if you're in a same-sex relationship and one partner has health insurance, not all states and not all organizations will offer health insurance to the couple. We are lucky here in Wisconsin that we do have that. We can have domestic partnership, but because same-sex marriage or domestic partnership is not a federal law, people that are in same-sex relationships and share health insurance have to pay more money for that health insurance. They have to pay taxes on the value of that health insurance. So again, another way that this population has reduced, financial, it is. So lower rates of health insurance. As people turn 65 plus, they are eligible for Medicare, as many of you know. But this can also, be a concern that maybe they weren't getting the treatment that they needed before, the preventative services before. Their lack of access of healthcare may affect them as they age. And as I just said before, higher rates of HIV/AIDS, chronic mental and physical conditions. Here's the statistic. 29% of people living with HIV are 50 and over, and 75% of people with HIV are 40 and over. And again, that stems from medical technology, antiretroviral therapy. But then as people age, if they're part of the LGBT community and they're HIV positive, they're dealing with all the issues around aging and having a serious mental illness, which can also bring along some psychosocial issues with it. So there's a lot that we see with that. And so we also see an increased risk of certain types of cancers. We see this in both the LGBT population overall and elders as well. A lot of this stems from lack of screening from earlier in their life. For a while, I know there's a statistic, but for a really long time, lack of pap smears or mammograms for lesbians was a common practice. They didn't do those as often. We see high rates of mental health issues and substance use. Substance use is huge amongst the LGBT population. One, if we think back to during the Stonewall era, bars were a place that this population gathered. This is where their friends were. This is where they could be out. This is where they could be themselves. And so they've sort of continued those friendships or utilizing bars as a place to gather. And then smoking, the rates of smoking are huge for lesbians. They're 200% more likely to smoke than any other population. That is huge. So we see cardiovascular disease as an issue, especially as people age. Obesity, again, lesbians tend to have there's a higher rate of being obese in the lesbian community, and then of course that leads to cardiovascular disease, diabetes, and other healthcare issues, and higher rates of depression and suicide. So yeah.
How would obesity be part of that?
That's a good question. And so there's not really an answer, but this is a little bit of what I think and a little bit of what I've read, is that there's not quite the societal pressures to have that certain special kind of body that men would be attracted to. There's still societal pressures. Obviously being a woman in our society, there are a lot of pressures to meet certain standards. But that is one thing that I've read about. There may be some other too. There's this whole minority stress theory that's out there around this population too, so we could look at that as well.
Do you know why smoking rates are so high?
I don't, and when I read that, if I were to take a total guess, I would have said gay men, really. I never would have guessed lesbians, but I do not know why. I really don't. So, anybody have any idea about maybe why? No, okay, yeah, me neither. So I wanted to just mention, because I mentioned earlier when we're looking at depression and suicide, we're also looking at social isolation as this population ages. So social isolation leads to, can lead to more mental health problems, loss of mobility, which is then linked to physical health and cognitive impairment, premature morbidity and morbidity and mortality. And so I didn't talk too much about nursing homes here, but that's another place where we see issues and health disparities, lack of cultural competence, and many of this can also be seen in nursing homes. So then the third challenge I wanted to talk about was reduced social support and community engagement as this population ages. So this LGBT elders really do lack the access to traditional social supports that we see heterosexual people having. So they may or may not be partnered. Same-sex couples or people in the LGBT population they have a higher rate of not having children. That is really changing with the younger LGBT population. The rates of having children is going up. But when we're looking at elders, maybe they had children from if they were married before, but their rates of having children is still lower. And they may not have the social supports from blood relatives. Again, this is going to stem from discrimination, victimization from earlier in their lifespan. And so they also feel that they are disconnected to the broader LGBT community. And when I was reading this, I really did think about this, and I thought, they say that the LGBT movement doesn't engage elders in some of the social activities, and I think that's probably really true. When I get the emails from the LGBT Campus Center, or I see things going on, and I worked really closely with the LGBT Community Center here in Madison. I helped organize a conference about LGBT elders. I worked really closely with LGBT elders with that conference, and they feel really disconnected to the LGBT community overall. And they feel like they want to do their own social things. And so there isn't really this support that we have from the younger generation for the older generation. So this also, yeah.
Is there any type of community organization for LGBT elders? When I was at the VA, I had a client who was an elder gay man, and in the substance abuse program. And his difficulty was because he didn't have a partner, he was new to the area, he didn't know how to connect with sober gay men. And
of his age,
yes,
right?
Of his age, and because he also lacked transportation issues due to
big issue
alcohol history. So I'm just wondering, is there anything that's being set up in Madison for that?
Well, that's a good question, and there is. What is the name of the community center in Madison? Outreach, thank you. It's like it's totally blanked on my mind. So Outreach is a community center for the LGBT community here in Madison, and I think most of southern Wisconsin overall. That is the best resource that we have, really. When I was gathering resources, when I was an intern at the VA, I went in there, and they have like a wall of pamphlets and stuff like that. And there may very well be an AA group with them, or some sort of sober group. I don't know specifically, but it is definitely something that is lacking more in this community. And like I said, I did work with LGBT elders there, and there was a handful of them that they did really feel disconnected to the community overall, especially the younger LGBT community. And the one woman I worked really closely with really made an effort to get involved in like the writing groups that they offered and the theater groups and some of the stuff that more of the younger people utilized. So, but you bring up a really important point that transportation is a huge issue for this population. So we may be able to offer some of these services, but do we have the transportation in our community to get them to these activities? That's another thing that we need to consider. And then they also feel unwelcome in aging programs, senior centers, volunteer centers, places of worship. Are there other people like them there? Is there an environment when they walk in that they feel like they're accepted? I talk a lot about this at the VA, and I'll talk a little bit about creating a welcoming environment. But something that somebody in the LGBT community does when they walk in anywhere is they scan. They look around the room and they're like, what's the sign showing me that I'm accepted here? What's the sign that I can be myself here? And that might be the magazine in a doctor's office. That might be a rainbow sticker on a door. It might be other people in the waiting room that are like them. And so if senior centers, volunteer centers, and places of worship don't have these signs, they're not going to want to utilize them, and this is just going to create more community disengagement and more isolation for this community, especially if they can't get out due to transportation issues or stuff like that. So we also see housing discrimination is another issue. They're often treated differently or even denied housing based on sexual orientation, gender identity. Not every state protects this. I don't know all the states that do, but not every state does. So people can discriminate against you for jobs and housing based on your sexual identity and sexual orientation. So not every state does protect that. 33% of gay and lesbians reported feeling like they have to hide their sexuality if they move into a retirement community. This is huge. I could do an entire hour lecture on long-term care facilities moving into retirement communities. They either have to remain in the closet or they have to go back into the closet. Oftentimes, if they have to go back into the closet, they feel separated from their families of choice because they can no longer be who they are. They can no longer have that type of relationship with them that they did before. And it can also lead to homelessness for this population. My next slide is a quote about moving into a long-term care facility for somebody in this population. I'll read it because it may be a little fuzzy back there. Two friends of mine, Vera and Zeta, had been together for 58 years. When Vera's Alzheimer's became too much, Zeta moved her to an assisted living facility. Zeta could barely trust family or neighbors with the truth, let alone strangers. So she and Vera became sisters. Much later, after Vera's death, Zeta needed to move into an assisted living facility herself. She had many, many photos of the love of her life, but dared not display them in her new home. The other residents would talk about husbands, children, and grandchildren, but she felt too vulnerable to tell the truth. Zeta was hiding and terribly isolated. Really very sad. Just heart-wrenching to know that maybe they were out their whole life for their whole 80, 70, 80, 90 years, and all of a sudden they have to move into an assisted living facility and they have to completely shut that part of their life out. Really sad. When I read this the first time, I just started crying because I thought, oh my gosh, I just can't even imagine. And then all the fears and concerns that that anybody has moving into an assisted living facility as we age. On top of that, add the fact that people might have to go back into the closet and not be able to have pictures of their loved ones and not be able to have their relationships with their loved ones. Okay, enough with the doom and gloom. So I wanted to move into a few policy gains that we've seen. This is going to be specific to healthcare facilities. This is what I know most about. This is what I've done my research on, and a very important topic specifically for this population. So maybe you guys have heard of the Joint Commission. They're an accrediting body that accredits hospitals and healthcare facilities that receive Medicaid and Medicare funding. So you have to be accredited by the Joint Commission or you're going to lose your federal funding from them. So this just happened, as we see. It came into effect at the beginning of 2011. It was factored into their accreditation in January of 2012. And what they're saying is that the Joint Commission now requires hospitals to provide care, treatment, and services free from discrimination. They've always included age, race, ethnicity, religion, culture, language, socioeconomic status, sex, but they have included in that sexual orientation, gender identity, or expression. So this has to be a written policy. It has to be displayed, and if it's not, they can get, they can either lose their funding or they can get certain X marks till they change that. So I wanted to share, I wanted to add one other thing to that slide, sorry. The Joint Commission recently came out with a field guide. It's called Advancing Effective Communication, Cultural Competence, and Patient and Family-Centered Care for the LGBT Community. And it's excellent. I really, if anybody's interested in social work and healthcare settings or at all interested in healthcare disparities, I highly recommend getting your hands on it. If you need a copy of it, I have an electronic copy. I'm happy to pass it on. I think they did a really nice job, and I think that they're really trying to get healthcare facilities to really make a more welcoming environment for this population. So, sorry, back to the visitation rights. So I wanted to share a really brief story about a lesbian couple that had been together for over 18 years. They had 2 children, they were on vacation, and one of the women had a serious medical emergency and ended up in the hospital. And what happened was she ended up dying there in Florida in the hospital, and her partner and her children could not visit her in the hospital when this happens. They had medical advance directives, healthcare power of attorneys, all of the stuff that we, highly recommend our same-sex couples to get. And she was still denied access to her partner's side when she was dying. So President Obama got wind of this and gave the Secretary of the U.S. Department of Health Services and the Joint Commission 6 months to get a new policy written, and that's what was written. So it requires that hospitals explain to all their patients their right to choose who may visit them during an inpatient stay, regardless of whether the visitor is a family member, a spouse, a domestic partner, or another type of visitor. This is huge. This is a huge change that's happened. I really hope we see it in long-term care facilities and nursing homes, but this is huge. I actually worked with a lesbian couple at the VA, and she was denied access, and it was really devastating to hear her story, and it was a couple of years ago, and they had been together for over 30 years, and then all the fear of being a veteran and don't ask, don't tell, and that was just layered upon layer. So this is a really big policy change that's happened. And again, like I said, these rules apply to hospitals as a condition of their participation in Medicare or Medicaid programs. I have my clicker. So this is what hospitals need to do in order to comply. They have to have a written policy concerning patients' visitation. I wish that I had a copy of the one at the VA. I used to, but I don't have it anymore. And what I will say is they changed it. Like I said, it was accredited January or February of 2012. That's the date of their memorandum for the policy change. So all these hospitals did it at the last minute because they had to do it because they were going to get, the Joint Commission was going to come around. So they have to have a written policy. They have to provide notice to their patients of their visitation rights. Has anybody ever been given a written policy of their visitation rights? When I talked to people at the VA about this, many healthcare providers didn't even know there was a change in visitation policy. So this is another issue we have with written policies and then how they get communicated down to people like social workers or healthcare providers to be able to talk to our clients about it. So they can't restrict, limit, or deny visitation based on all of our protected things, including gender identity and sexual orientation. And that they need to respect the rights of same-sex couples as a patient's representative to make decisions on their behalf. This is also really important. Having a medical, durable healthcare power of attorney, advance directive, they need to recognize that. This has been a huge issue that we've seen in healthcare and hospitals overall. So they can now visit them and they can recognize their healthcare power of attorneys. So hopefully this will come into more practice and it's not just a written policy that's sort of floating around. So what is our role as a social worker? So I've kind of given you guys all this information, and we're all studying most people in here are studying social work, and we're going to go out into the field, and inevitably we're going to come in contact with the LGBT population or LGBT elders. So what is our role? And I personally feel like that we have an ethical responsibility to be culturally competent, to become educated in cultural competency for many of the populations that we work with, whether they're racial or ethnic minorities or they're gay or lesbian. And that we, as social workers and being in school, we get to learn about culture. We get to learn about how culture affects who we are and how we move about society and how we move about the world, and that it's a part of all of us. And that we, as social workers, have to seek and promote sensitivity to knowledge about oppression and cultural diversity. This is sort of, I feel like, at the heart of our training as social workers. We are bound by the NISW Code of Ethics. We respect the inherent dignity and worth of individuals. And that we're change agents, and we're responsible for educating both our clients, ourselves, our coworkers, our organizations, our communities, and our politicians about these issues. And we're part responsible for trying to make these changes happen, about educating people about it. So, you know, I started to do that at the VA, and it was such a great experience. I had the opportunity to talk to all the doctors and primary care nurses at the hospital about these issues, and it was really a wonderful experience for me. I was totally terrified and nervous, but they all sat in the room and they had no idea about these policy changes. And I feel like as a social worker, that's my role to educate my coworkers. And I might not be in a social service environment. I might be working with other care providers who are not trained as social workers. So I think it is really important that we can advocate for all of our clients. So I wanted to include that. And then I wanted to include this, just one slide, as to become a supportive healthcare provider. And I say this for people who are in the health, aging, and disability field who may be working in healthcare. And even if you're not, that one of the first steps to becoming culturally competent is to evaluate your own belief system. So to really look at, what are your biases? We all have them. So what are they? And to really evaluate those. And then to really understand what the risk factors are. What are the risk factors of this population? When we look back to the slides that I talked about before, when we were talking about access to care and fear about healthcare providers not being adequately trained, we really need to know what the risk factors are for the populations that we're working with. And then to modify our intake and interview, this is if you're doing a psychosocial assessment or if you're interviewing somebody as a client or whatever, to really try to incorporate a more diverse and inclusive language for all people. I included a few things here to help create a welcoming environment. A couple of signs. Prominently display the hospital non-discrimination policy. I've never seen it displayed at the VA. I'm still waiting for them to do it. To incorporate and integrate a broad definition of family. Avoid assumptions about sexual orientation and gender identity. And really, as social workers, familiarize yourself with all of the resources that are there for any of our clients, and specifically GLBT elders overall. And that's it. I left 10 minutes for questions.
Great. So I have a quick question. Having, unfortunately, I had a number of loved ones in the hospital recently. I have yet to have any of them mention being asked who should be allowed to visit them or anything along those lines. The healthcare power of attorney or a living will is sort of part of the intake process, but that specific issue of visitation or whatever, should we be asking questions about that? Is there an appropriate way for us to advocate from the patient perspective about these changes, and are they being implemented throughout the hospital culture?
I absolutely think we have every right to ask.
Okay.
I really do. I have never seen, they say it's supposed to be prominently displayed. I have never seen it prominently displayed. And I remember asking Andy did his internship last year at Divine Savior, and I had asked him if he wouldn't mind getting the visitation policy for me, because I wanted to talk to a few students who are in my internship. What is the visitation policy? He couldn't find it, and he found what was on their website, which was like 3 sentences long, and it said nothing about any of that stuff that I talked about. So I think we have every right to ask, and I say, fortunately, I think a lot of people in the LGBT community are really knowledgeable about what their rights are because they have to be, because they have to advocate for themselves. So many of them might already know this exists. It's unfortunate that they have to actually advocate for themselves in that way.
Well, and personally, I think those of us who are active allies, it's a way to let the hospital know that it's not just LGBT individuals who care about these policies. If we can push it, anyway. You can
Absolutely, absolutely, yeah.
Thank you.
You're welcome. Any other questions? Tracy?
So I would just add a thought to Ann's thing, and that is that, you know, I think that I think different generations are more likely to advocate for themselves. This generation of elders is not. They're not. They're the ones that, you know, they were before Stonewall, you know, and even after Stonewall, they've gone in and out and in and out of the closet. And it's been they've had times where for them, it's just not safe. So I think there's where, you know, I think about opportunities for social workers to advocate at senior centers and other places to make people aware, but also families, because a lot of times it is the family that's going to have to do that. So I think it's an important thing to think about different generations of elders. I don't think we have to worry about the baby boomers. You know, we're pretty vocal on our various stones.
I guess I was going to kind of ask a question along those lines, like if you think that, like, especially like your first half, a lot of the problems with feeling insecure and like even like poor treatment when they actually go to those types of facilities, if you foresee that even without policy changes, that maybe that sort of load to be lightened on, like say maybe like someone like my age when I'm 70 years old, like maybe would have less stress even without changes. Like I'm just like curious, like if you've seen any trends, like as far as like maybe like even the 40-year-olds having like less of those issues than 70-year-olds because of what they've been through.
Well, I do think there's a lot of changes going on. And I say specifically, I brought up the Joint Commission, LGBT, Cultural Competence, Family-Centered Care. That wouldn't have happened 10 years ago. They would not have created that field guide. So that is huge. And when I did my most recent talk at the VA, the 4 top people, the director of the hospital was at my talk. So they want to know what they need to do to create an environment. Regardless of what the policies that are coming down, they know that they need to be more open to this population. They know they need to create a more welcoming environment. So I do think change is happening. I don't always think that that just because we have a policy change means it's going to trickle down. Like, I look at Don't Ask, Don't Tell, and we don't have that anymore. Do you think people still feel safe coming out in the military? I see people, my clients at the VA, they're terrified to tell me that the person sitting next to them is their partner. And we're the VA, we're not the military. You know, there's still a lot of fear. So I do think things are changing. I think it takes a long time, and I really don't think that just because we have a policy change means that it really trickles down to the people. But yeah,
what are you
I like to be
noticing among providers as far as receptivity to the policy changes? They're actually out there trying to implement.
Well, I haven't seen any implementation of it at all because I don't really, I don't do any inpatient social work, so I haven't seen, you know, the visitation really has to do with inpatient more. But I really saw a lot of receptivity from the providers overall, which the one thing I was most alarmed about is that they didn't know that it existed. That is the thing that I was most like, whoa, this has been written for a year and they don't know. So what does that say about our written policies at an organizational level, and how does it trickle down to the workers? I think that there's a lot to be said about that. And I'm not singling out the VA. I don't think that the VA is, you know, I'm sure if we looked at other hospitals or other large care facilities, it would be similar. But I was really surprised they didn't know about it. Yeah. Yeah.
One thing I would say though is, like, I knew at the VA they were starting to develop a group for LGBT individuals in the VA, and they also had a support group for transgender individuals as well.
They did.
So I was watching that come up last year when I was interning there, and that was really exciting.
Yeah, absolutely. They're doing, I mean, I think they're doing a good job. I mean, I think that all of these organizations can do a better job, and that's why I put the responsibility on all of us as social workers to get out there and really do that. You know, I know that we all in our program have to take racial and ethnic study. What is the class called? Yeah, and one of the things that we have to do for one of the papers is we need to assess our field placement and assess how culturally competent is it for racial and ethnic minorities. I say do that for all minorities. Go to your field placement and look and see, you know, how accepting is this place to anybody who walks in. Look at the people who work there. Are they all white women? Are they all white men? You know, is anybody gay? Is anybody a racial ethnic minority who works there? So kind of assess, you know, where you work, whether it's a large hospital or it's a small social service organization. And I feel like there's always things we can do to educate both ourselves, our clients, and our coworkers about becoming, you know, more competent in all of these different populations. Anything else? You guys have my email. If anybody wants any of the research, feel free to email me. If you want any information, I'm available. And Tracy also knows how to get in touch with me. Thanks.
Health and disability, thanks.